Good morning. Can you see the slides?
Yes, we can
Yes.
see it very well.
Okay, good morning. Assalamu alaikum. And it's a great honor for me to be at this webinar with colleagues and friends from Egypt, Africa, and all over the world. I truly appreciate this kind invitation from the Egyptian Society and CANS. It's a great honor to join the podium with Professor Qureshi and to be here with Professor Beltagi and El-Ghandour. I will focus on the first talk and focus on the treatment of hydrocephalus in spina bifida patients. And the second talk will focus mostly on the fetal in utero surgery for spina bifida. As we all know, spina bifida is the most common well-known neural tube defect, and it causes incomplete closure of the neural tube dorsally. Now, here in the US and North America, the rates remain around the range of 1 to 2 per 1,000 pregnancies, but I know in Egypt I believe it's around 4 to 6. Other parts of the world can go up to 7 or 8. We know the etiology can be multifactorial, but we are fully aware that genetic and environmental factors remain the main factors contributing to the development of spina bifida. Folic acid remains the only prevention we can know right now. The recommended dose here in North America for mothers about in childbearing age, about to become pregnant or to be on at least 0.4 milligram folic acid daily. And all the studies systematically showed significant reduction in the rates of neural tube defects. If we go back to the embryology and how does the spina bifida defect develop, we all know that around 21 days of gestation, we start to see the early stages of neural tube closure, where the neural plate will start involute and separated from the neural crest and the ectoderm. And if we do look around 28 days of gestation, we start to see the early signs of spina bifida. Around 29 days of gestation, if there's anterior neuropore closure, we end up with the anencephaly, and posterior neuropore closures ends up with the spina bifida. There are 3 major types of spina bifida, as we all know. The most severe type is spina bifida cystica, or myelomeningocele, while the most, or the mildest form is spina bifida occulta, where you can have a patch of hair or skin changes and the dorsal elements of the spine would be missing, but there would be no tethering in most cases. But there's some like fatty phylum or other types of tethering, but no protrusion of dura like in meningocele, which is less common, but also can be associated with some tethering of the spinal cord, but not much of hydrocephalus or Chiari. And this is the most severe form of myelomeningocele. I tried to find some epidemiology studies from Egypt and Africa, and the rates in most of Africa range around 4 to 6 per 1,000 pregnancies. And this study in Egypt looked at risk factors and they mostly were looking at the lack of folate supplementation and the history of anti-epileptic drug intake, and the rates are around 5 per 1,000 pregnancies in Egypt. The standard of care, and I would like to focus on the word that the standard of care remains to perform the postnatal repair, typically in the first 1 to 2 days. Usually we do it in the first 24 hours after birth. Those are 3 babies from my own practice. I still perform postnatal repairs for selected cases that did not qualify for fetus surgery, or they declined fetus surgery, or they presented late in pregnancy and they did not qualify for prenatal investigations for fetal surgery. If we look deeply into the pathophysiology of spina bifida, how does it cause the intracranial anomalies? We know there are many theories in the past, but the one we can accept the most is that there is a negative pressure environment at the craniocervical junction during early stages of pregnancy due to leakage of CSF, cerebrospinal fluid, through the spina bifida defect, leading to this negative pressure environment at the craniocervical junction. and leading to the fourth ventricular outlet obstruction. The whole posterior fossa anatomy becomes smaller, and this leads to obstructive hydrocephalus. Spina bifida is not only about hydrocephalus. Those children, as we all know, they have motor and cognitive impairments, bladder, bowel dysfunction, spinal deformities, and many social and emotional challenges. Again, if we look deeply into the pathophysiology, here are the three things we focus on: myelomeningocele, Chiari type 2 malformation, or hindbrain herniation, and obstructive hydrocephalus. Now, if we look at 75% of the cases, they also have aqueductal stenosis associated with the intracranial anomalies, which is extremely important when we start looking at treatment options. In the 1970s, since the shunts came out, the survival of spina bifida patients went dramatically from being in the 50s up to the 80s. And now we know the survival is much higher as we treat this hydrocephalus better. The lower the lesion, the lower the chance for hindbrain herniation and obstructive hydrocephalus. And the higher the lesion, like in thoracic or even cervical myelomeningocele, the shunting, the rates of shunted hydrocephalus are way above 90%. A recent focus series of papers on spina bifida came out in Neurosurgical Focus last year, showed very interesting data that when they looked at the last 15 to 20 years, they actually found that most neurosurgeons are accepting some delay if the patient clinically can tolerate some delay in the treatment hydrocephalus. And many neurosurgeons, including myself, if the baby after birth can tolerate clinically and radiographically, the interfontanal, the head circumference, apneas, bradycardias, as long as the baby is stable, most of us, including myself, I will try to delay treatment, not during the first admission, and monitor for the development of the pre-pontine cistern, and try to find a way if we can avoid a shunt if possible. There are many babies who cannot allow us to do that, and we have to treat them with a shunt placement after birth and after we repair the myelomeningocele. But this study showed clearly that there's a more accepted culture of delaying the treatment, although a meta-analysis demonstrated that the shunt malfunction or shunt infection rates did not differ between those two groups of early or delayed treatment. We're not going to focus today in our talk about shunts because we all know what to do with shunts for spina bifida. I will try to focus on other modalities. We all know that ETV is considered to be controversial in patients' spina bifida. This has to do with the fourth ventricular outlet obstruction. You can see there are a lot of data from the 1990s looking at some groups are going for the ETV and supporting it, and many others are against it. Why are we looking at ETV? Our mentor, Professor Hal Rickett, always described the shunt as a sentence, not as a procedure. And it is truly a sentence for patients with spina bifida because it's a long-term, lifetime commitment. And we all know the shunt-related complications related to occlusion, infection, disconnection. And we all know that in our lifetime after placing a shunt, there's 80% chance of complications. On the other hand, if we look at the anatomy in spina bifida patients, here you can see this is a classic MRI of patients' spina bifida. Small posterior fossa, aqueductal stenosis, very limited pre-pontine cistern. The cerebellar tonsils go down to the middle of the cervical canal, large mass intermedia, very limited space anteriorly within the third ventricle. This whole anatomy makes it challenging for surgeons to consider ETV unless the anatomy is very favorable. Nonetheless, the most recent data is showing that if we can try it, we should try it. And if it can be done safely and the surgeon is comfortable. For instance, this is a patient with spina bifida. Mass intermedia is fine. The Chiari is not too bad. This is a lumbosacral lesion, obviously, not a bad Chiari malformation. There's some stenosis here. And you can see the ETV. This is a very favorable anatomy for an ETV. This as well, Yes, you have some Chiari. Prepontine is open. Massa intermedia is not bad. Nice space to try an ETV. Why not? We should try it if anatomically feasible and the surgeon is comfortable, and give it a chance before assigning the patient for a shunt. Obviously, we'll talk later about the age. How about this patient? This is a baby with spina bifida I took care of, or who has clearly crane cervical junctional compression, Chiari malformation, and a syrinx. Prepontine cistern is completely gone here. This is a patient I went ahead and placed a shunt. I'm not going to even consider ETV for this scenario. If we look at the ETV success score by Kulkarni and colleagues, you can find that when they looked specifically at the success score, you can find that spina bifida fits into the lower scoring system, which tells you that if you have a spina bifida in your patient and you try to calculate the ETV success score, you're going to have a lower success rate if you make the calculation. I'm hoping this grading system or ranking system will change in the future as we explore other ways to treat spina bifida. In the last 10 years, where there's more and more interest in ETV and choroid plexus cauterization or coagulation. We know that data started all in Africa from Uganda. Professor Worf and his colleagues in Uganda looked carefully at ETV CPC in infants under the age of 1 year, and they found very promising results in avoiding shunts in this high-risk patient population in Uganda. And when they tried to do a similar study in North America, the Hydrocephalus Clinical Research Network, they did a study here in North America. They found actually that some of the results from Africa can be replicated here in North America. They demonstrated that ETV CPC, it is reasonably safe, and the degree of CPC, how much coagulation we do, might be associated with a learning curve and may affect the success. And this will lead to a prospective randomized trial, which is starting actually this summer. I'll talk to you about it in a minute. How about spina bifida specifically? When Professor Worf and his group looked at over 100 East African infants in the first year of life with a history of myelomeningocele, they actually found that ETV CPC2 appears to successfully provide more durable primary treatment for hydrocephalus than shunts, given the high risk of shunt-related complications in this patient group. I personally, my practice, I started around 8 to 10 years ago, performing a lot of CPCs with the rigid endoscope. I'll show you many videos of different techniques. For instance, this is with the rigid endoscope, CPC performed on the right ventricle, his massa intermedia. Here you can see the ETV and membrane of Lilliquist. We go through, we can see the lower cranial nerves, and then we go back and look at the contralateral hemisphere, and this is CPC was completed. But look carefully here at this picture. This is the glomus, has been coagulated. The glomus of this choroid plexus within the atrium, almost occipital horn of this ventricle, on the contralateral side, I can see what I can see with the rigid endoscope. The truth of the matter is that this choroid plexus is going to curve in a C shape into the temporal horn, and we are going to miss unless we try flexible endoscopy. In Uganda, Professor Worf and his group performed all their ETV CPCs with a flexible endoscope, and they were able to achieve maximal cauterization of the choroid plexus into the temporal horn of the lateral ventricles and achieve probably higher success rates. On the other hand, some colleagues in Miami looked carefully at rigid endoscopy versus flexible endoscopy. They found some evidence that you need to coagulate over 90 to 95% of the choroid plexus to achieve maximal successful outcomes for hydrocephalus, but they did not actually find statistically significant results to suggest that flexible endoscopy is better than rigid endoscopy. I was fortunate last year to spend time at the Children's Hospital of Uganda in Bali, Uganda. It was a great experience with me to go to the hospital where most of the, or all the experience of ETV CPC started. I know in Kenya, Tanzania, and other parts of East Africa, there are wonderful programs happening as well. This is the setup they have in Uganda, and I truly have now in my practice in Florida the same setup when it comes to the positioning. We'll show it in a few minutes in lateral position. The flexible endoscope, there are two types. There's the fiber optic and there's the digital. This video is using the fiber optic. They do not use the balloon. This is the aqueduct. You can see here. This is the fourth ventricle. We come back and direct the tip of the flexible endoscope into the floor of third ventricle anterior to the basal artery, and you start with making very minimal coagulation. This is the technique in Uganda. In my practice right now, I do not coagulate. I just do a careful blunt fenestration anterior to the basilar artery, followed by dilation with a Fogarty balloon. But this is the technique that's used with good results. And here you can see there's entry into the prepontine cistern all the way. You can see here there's some arachnoid covering the basilar, and it's extremely important to go back and try to achieve opening into the arachnoid surrounding the basal artery in order to achieve communication between the third ventricle, prepontine space, as well as the arachnoid surrounding the basilar. The next step, we direct our attention to the choroid plexus and the ipsilateral ventricle and try to proceed with coagulation and some periodic or dynamic irrigation as needed. There's truly a learning curve to perform CPC for this patient population, specifically spina bifida. There's the technique of rotating the endoscope to get into the temporal horn of the ventricle and achieve maximal coagulation. Again, the goal is to achieve at least 90 to 95% of choroid plexus cauterization, affecting the body, the atrium of the lateral ventricle, as well as the temporal horn, followed by crossing the midline via septal fenestration if needed, and perform the same technique on the contralateral side. Here in North America, the endoscopic versus shunt treatment for hydrocephalus in the first year of life trial, the ESTHI, is starting literally this summer. And this will be funded by the NIH, and we hope that in the next 3 to 5 years, we will have a prospective randomized trial results looking specifically at neuropsychological outcomes, radiographic outcomes for ETV CPC compared to shunts, and hopefully we'll have a similar promising results. Again, in my practice, I do the patients, the babies in lateral position. Here I'm marking the right corner of the anterior fontanelle. I'm marking my incision, patient lateral position. This is the holding arm, and this is the flexible endoscope. This is our setup in Orlando right now. Very similar to the setup I used in Africa. We'll talk in the next lecture on the fetal in utero surgery for spina bifida, but in this very specific patient population, this is a fetal MRI a few weeks after fetal surgery. When we have reversal of the Chiari malformation, like in this patient with who had in utero spina bifida surgery compared to the classic spina bifida, you can see the anatomy is more favorable for ETVs. And that's what we started doing around 2014, that most of our patients who had fetal surgery underwent ETVs before assigning them to a shunt. For the sake of time, you can see here the anatomy of the floor of third ventricle is very favorable for ETV compared to the classic ETV or anatomical challenges you deal with in patients with spina bifida. Nonetheless, the technique is the same when it comes to making sure that if there's any secondary membrane to do secondary membrane fenestration, dilation, and then get the endoscope into the prepontine cistern to confirm there's a naked basilar artery with no further adhesions. Ventricles coming down, and after 3 years, you can see the anatomy, the ETV remains patent, and although the ventricles remain dilated, but the head circumference continues to do well, and we follow those kids with neuropsychological testing to make sure they were not missing any delays. More videos. This is a patient also had fetal surgery, but you can see not in all of them, the anatomy is very favorable. Like in this case, You can see their interthalamic adhesions at the floor of the third ventricle. And in my opinion, this should not stop you from attempting ETV as long as you're comfortable with it. Sometimes you need to do hydrodissection to see the tip of the basilar artery and pulsations, but the goal is the same, to achieve good communication with the pre-pontine cistern and achieve an ETV that you can trust, and in this case, anterior to the interthalamic adhesion. Another video, all those with the rigid endoscope. I'm trying to show you videos, both rigid and flexible endoscopy. Another case of interthalamic adhesions, and the ETV is done anteriorly with good communication with the pre-pontine cistern. You can see different variations of the floor or the third ventricle when you attempt ETV in this spina bifida population. For instance, all those 4 patients have spina bifida. You can see the top right, the floor looks essentially normal. On the top right, you can see here, fenestration anterior to the, or the stoma, or fenestration is made anterior to interthalamic adhesion. Look at the bottom left. This video, the fenestration was made posterior to the interthalamic adhesion, and similar in this video where the stoma was also performed posterior to the stoma. So going anterior or posterior does not matter as long as you're comfortable with the anatomy of the pre-pontine cistern and try to localize the basilar tip with different techniques. When we looked carefully at our data for ETVs in spina bifida patients who had fetus surgery, we did 24 cases in this published paper, and we had a very low threshold actually to place a shunt. If there's progressive macrocrania, any developmental delays, any increased ventricular size, any syringomyelia that's new or progressed, we went for a shunt. If we looked carefully at our ETV success rate in this group, and our babies are all of them in the first year of life, the success rate is between 50 to 60%. Most interestingly is that if you look at the overall shunting rate from this study we did in St. Louis, was around 29%. So if you look at all spina bifida patients and you're cutting down the shunting rate down to 29%, it is truly a great achievement if we can reproduce those results and follow those children very carefully when it comes to neuropsychological testing and making sure that clinically we're giving them the best hydrocephalus outcome possible. When we looked at the risk factors for ETV failure in this group that had spina bifida repair in utero, we find that the risk factors are similar to other studies. If we do the ETV under 6 months of age, that's a risk factor for failure. In the case of gestational age at the time of fetus surgery, under 23 weeks of gestation, we'll talk about it later. This is really allowed us to look closer into the pathophysiology. You know, when we perform ETVs for patients who have spina bifida, again, the things to look for: what is the status of the Chiari? What is the status of the aqueductus stenosis? What is the width or dimensions of the pre-pontine cistern? Is the anatomy favorable at the floor or the third ventricle? Is the surgeon comfortable and has some experience? In my opinion, if all those answers are yes, then in my opinion, ETV should always be tried first, unless some of those risk factors are concerning. The question is, should we try ETV for every myelomeningocele? And the answer is no. Again, this is a very good potential candidate, but this one, it's not, as we discussed before. How about ETV in the setting of sham malfunction in patients with spina bifida? We know Professor Cinali and the Italian groups published extensively on the use of ETV in patients with shunt malfunction. And in my opinion, this should always be tried if the patient is stable enough to undergo imaging and the anatomy is favorable. And the success rate for ETV at the time of sham malfunction in many studies ranges anywhere between 50 to 70%. So what do we do with the shunt at the time of the ETV? You have many options. If a patient comes today with a sham malfunction, I will try to get an MRI or even fast sequence MRI, a quick one, to understand the anatomy. and if the patient is stable enough, and I do ETV and I'm happy with the ETV, I have the option to revise the shunt and ligate it distal to the valve. I can use a programmable valve available and upgrade it to higher pressure setting. Some valves have the virtual off option. You have the option to remove the shunt. You have the option to remove the shunt and place a drain and clamp it, or you can remove the shunt and place a reservoir to have it available for emergency access. This is a baby who had a myelomeningocele. You can see the Chiari. And this patient had a repair after birth, had a shunt placed at 3 months of age, presented at 15 months of age with shunt failure, and we did an ETV. Again, there is Chiari, but the anatomy is favorable. So I went ahead and revised the shunt, but used a programmable valve to take the setting higher. You have the option to remove the shunt as well or place a reservoir. Here you can see the shunt catheter, and this is the ETV. Again, this is over the age of 1 year, so there is no evidence that CPC is helpful. Interthalamic adhesion, and the ETV is done just anterior to that with a beautiful communication with the pre-Pontine cistern and good pulsations. Post-operatively, this patient remained until now doing very well a few years later with ETV very patent and successful, and the hydrocephalus under good control and without the need for maximal shunt function, and the ventricles came down. And for the sake of time, I'll conclude that in the setting of hydrocephalus in patients with spina bifida, using your best clinical judgment regarding treatment of hydrocephalus and its timing, you can delay the treatment if the baby can tolerate. Obviously, we need to look at the common factors, the head circumference, anterior fontanelle, splaying of the skull sutures, ventricular size, how's the baby's feeding doing, any apneas or bradycardias. We need to look at all those factors. And if the baby meets the criteria that should be treated for hydrocephalus, in my opinion, if it's in the first month of life, in my opinion, the shunt is the right thing to do. Once patients get to the age of 6 to 8 weeks, if the anatomy is favorable, I truly recommend to try ETV if you're comfortable and the anatomy is favorable. You should always consider the status of the fourth ventricular outlet obstruction, the status of the Chiari, as well as the surgeon's experience. We'll talk in the next lecture on the impact on fetal surgery and ETVs, but the ETV success score does not apply here in patients, for instance, who have fetal surgery, since the Chiari reverse and we may see changes in the future. I do believe that ETV CPC outcomes from the published results from Africa, in my opinion, we're seeing very convincing similar results in North America, and we hope the prospective randomized trial starting this year will give us the answer in the next 3 to 5 years. Thank you for having me, and I'm ready for any questions. Thank you.
Thank you, Samer, for this outstanding presentation as usual.
Thank you, sir.
I just want to have one comment or a question.
Yes, can I please? Can I just ask a question and comment, please?
Yes, Professor El-Ghandour, please go ahead.
Yes, thank you very much indeed, Dr. Samer El-Baba. It's very nice to compare the shunting and the ETV. I'm just wondered about the cases which has syrinx as well, Arnold Chiari and syrinx as well. Did you follow them, and did you do anything for the posterior fossa or decompression or artificial sterna magna for these cases? How long did you follow them? And how much time after doing any surgery for this syrinx, your syrinx disappear? Thank you.
This is an excellent question. Thank you, Professor. So it all depends if I always get an MRI before treatment. If the patient has a pre-existing syrinx, more likely than not, the craniocervical junction is super crowded, and I favor shunting in those cases. I lean away, like the case I showed you, lean away from ETV if they have a syrinx up front. If it's a tiny syrinx, and the anatomy is favorable and the pre-pontine cistern is open, I will try ETV. In my experience, if there is a syrinx high up in the cervical canal, in most situations, you will end up needing a shunt. Now, the other scenario is if a patient does not have a syrinx, we do ETV, everything is going very well, and now suddenly I'm starting to see new development of a syrinx. That's another indication the ETV is not enough, and I will go for a shunt. I have a very low threshold to convert from ETV to a shunt if I see any indication the ETV is not going to give the best outcome possible. I have followed many of those children for at least 10 years, and I found the patients with minimal syrinx and the hydrocephalus under good control. This is a third scenario. If the ventricles are stable or better after the ETV, but the syrinx is a little bit worse and the craniosacral junction is really tight, those situations I will do suboccipital decompression, C1 laminectomy without duroplasty, just to do bony decompression. And I found this combination of ETV and Chiari decompression without duroplasty to be a very effective strategy in patients when the craniosacral junction crowding is not too severe.
Well, I understand that your shunting or ETV will help syrinx, which is just not go with Williams' theory. You know, Williams has been knighted for his theory. Sometimes the syrinx extending not only cervical, especially in these kids, down to thoracic, and even the whole cord might be having syrinx. So I just wondered, and probably this is different from adults. Sometimes they Arnold Chiari without meningomyelocele. They present in adults with syrinx, and we don't do shunting because the main pathology is the tightness and the crowding, overcrowding, and the jammed structures at the foramen magnum. So doing that, probably I would take your point in not doing artificial graft, because in Sydney, I was in a meeting, I think in Perth in Australia, they take only the bone without doing any artificial graft towards dura. And they claim that they have a good result. But myself, my humble experience over the 40 years, I always do the artificial graft. I'm worried about not improving. And the start of the syrinx, they improving after 6 months, and probably they vanish after 1 or 2 years in the cases. So just probably the adult type different from the kids. Thank you.
Thank you, Professor Ghanem. Thank you, Professor
The pathophysiology
El-Baba.
can be different. Now, thank you. If the syrinx goes very low to thoracolumbar region, there's also possibility of tethering of the spinal cord and the spine bifida patient that we should always consider as well. Thank you very much.
We need to move to the Professor.
I think you have another question for Samer from
we can,
Mahmoud Kamal. This discussion is very important, really.
Okay, there is a question on the panelist, Samer, about repair of myelomeningocele first or ETV first?
Always repair of the myelomeningocele first, then monitor hydrocephalus symptoms.
So you do the repair first and then the ETV, okay.
And then monitor for signs and symptoms. If it's in the first days of life, typically I place a shunt. But if the babies can wait up to the age of 2 to 4 months and the anatomy is favorable, I will do ETV first.
Okay, there is another thing which I want to ask you. You do the ETV for the myelomeningocele. What about inserting an external drain after the ETV just to monitor the tension, since what you monitor after that is the criteria of gross and any delay in milestones. As you know, these kids, they don't present after except with cerebral atrophy or some delayed milestones. So to avoid this, what about inserting an external drain measuring the tension to see if this ETV is functioning, since the flowmetry alone would not give you a full picture? What do you think about this?
In the past, I used to place some external ventricular drains after ETVs, and I found the morbidity is not acceptable. There's no reason to place a drain which can cause potential infection or meningitis and complicate the whole treatment of this disease. I typically do ETV if it's under the age of 6 months. Sometimes I place a Recum reservoir available for access if needed, but otherwise in my practice, I do ETV, and if there's good hemostasis, I will do a good dural closure and close the skin primarily and monitor for signs and symptoms. I follow them in 3 aspects. Number 1, head circumference. Number 2, ventricular size. Number 3, in 6 to 12 months, 6 months after treatment, I'll try to do neuropsychological testing to look for any potential delays in milestones. And I have a very low threshold to go for a shunt if needed.
Okay, yeah. So we can now move to Professor Qureshi.
Wait, Professor
Since
Beltagi,
we're running-
Muhammad Arnaout is raising his hand. Maybe he wants to speak with Professor Samir. Arnaout. Muhammad Arnaout, you
we
are
are
already
out
in the
of
panelist.
time, Professor El-Ghandour. We can postpone any more questions in the second lecture because we are almost 10 minutes late.
Okay, okay.
Professor Qureshi, now we will speak about childhood hydrocephalus, a grading system to guide ETV decision.
Thank you very much.
Please.
Can you hear me, everyone?
Yes, we can hear you.
And you can see the slides?
Yes.
Yes.
Okay. Thank you very much, Samer. That was an extremely useful and educational talk. Listening to you obviously gives us the perspective of what is happening in the West. I will, with humility, bring you down to Africa, where most centers do not have the ability to investigate. Although we've been promoting ETV across the sub-Saharan Africa very much so. Obviously, the kind of investigations and the scanning and the MRIs are not available. So at best, we might have an ultrasound and sometimes a CT scan, but in view of the numbers, we just proceed and offer them the ETV and tell the parents that we may need to come back for this mission in a month's time. And if this persists, we may need to consider a shunt. So those are the approaches that we have in sub-Saharan Africa. And this is a snapshot on how the scoring system, ETV scoring system, can be utilized in our setting. This is then therefore a guide to ETV decision-making. And again, after listening to Professor Al-Baba's talk, it's obviously going to be a totally different paradigm because of the settings in which this childhood hydrocephalus is being treated. The current cutting-edge way of managing it would be what has been described very eloquently by Professor Samer Al-Baba. So this is the problem and the dilemma that we face. Just as it is globally, this is a significant problem across Africa. This is a day or a weekend that one has gone to do a mission in the country adjacent to Uganda, that's Tanzania, at a hospital on the Lake Victoria, much just like Entebbe in Uganda. And this is the Buganda Hospital. And you've mentioned a team coming in and all the mothers will arrive there and you have a dilemma, who to treat, how to treat. And this is just a day's work then on how many ETVs one then selects out to do at that Buganda Medical Center in Tanzania. Up until 2004, there was no shunt or ETV available in the sub-Saharan island of Zanzibar, which has been present for centuries. And this was the first child that was being shunted in 2004. So I'm trying to give a paradox and a paradigm which relates to the practice in some parts of the West with what the situation is currently in some parts or many parts of sub-Saharan Africa and Africa indeed. The procedure has been that we do is I'll very quickly go through the procedure using the curvilinear incision at the coccus point, 11 to 12 centimeters posterior, using a rigid endoscope. Mostly, very rarely have we used the flexible because A, the vision on our screens is not brilliant. We don't have the top edge screens. And two, the rigid endoscope is a much more versatile scope and doesn't break down as often as it does for the flexible scopes. And because of not having the luxury of being able to get many scopes, we tend to use the OI HandyPro for the ETVs. And this is the view upon entry into the right lateral ventricle. As you see, you first see the fornix, you then move through, you then visualize the mammillary bodies, you then go ahead and then perform your ETV as Samer very beautifully described. The intraoperative view is well known to most of us, but just for those who don't do ETVs very often in Africa, this is the view that one gets of the foramen of Monro, the choroid plexus, as was described in the videos, the thalamus striate vein, the anterior septal vein, and as you move closer, you then begin to see the tubercinarium, the infundibulum, the optic chiasm, the mammillary bodies, and you see in most cases, or quite a few cases, the pulsation of the basilar. And essentially, you want to go, if you measure the distance between here and up to here, you want to go at the junction between 1/3 and 2/3 to get a safe ETV done. We always use a blunt instrument, never use cautery in our cases here in this part of the world, because the few cases where one has had injury to the basilar have been reported. It was during the use of a cautery. This is again the third ventricular view from posteriorly, the infundibulum, the tubercinarium, and the mammillary bodies. The intraoperative view of the structures at the foramen of Monro and below, and this is a blunt instrument, forceps, that was being used in the area where one wants to do the endoscopic third ventriculostomy. So as we're doing this third ventriculostomy in some of these rural areas, the screens are not brilliant. This is the view one is getting. And while we are doing this, we're also doing training of those who are able to come to join us. The anatomy, very quickly, we need to go through. What one looks for are the two leaves of the membrane of Lilleküss. One must be very well aware that there is not just one, and as was described by Professor Al-Baba, the leaf that is covering the basilar artery must also be looked at and perforated through. That's the mesencephalic portion of it. So one sees the diencephalic portion of the Lilleküss membrane. You see perforating arteries. You will see the third nerve, and that's the reason for not going laterally, because you might damage the third nerve. And then you see the posterior cerebral artery as well, if you look into that space. The view through the membrane of Lilleküss, once you have perforated it, you will see the mesencephalic portion of the membrane of Lilleküss. You will see the prepontine cistern, the basilar artery, and the membrane of the diencephalic portion of the Lilleküss membrane, both, as I said, which must be perforated through. One would then see the posterior cerebral artery, and the left, the superior cerebellar artery is shown in this view. So you must see the vessels very, very clearly in order to have a successful ETV. In our settings, we see a huge number of anatomical anomalies, and this is another reason where the success of an ETV may become reduced. The anomalies include the absence of the septum, in which case there is just no septum pellucidum, there is no corpus callosum, there may be enlarged phoneal columns, interthalamic commissures, and large floating choroid plexuses, which basically obstruct your view. There may be narrow space between the dorsum cellae and the basilar artery. All of these, if one had an MRI, one might be able to pick out some of these anomalies, but in our setting, you actually meet them during the ETV. Oftentimes, there is no floor of the third ventricle, and it's just covered by an arachnoid membrane. And all these anomalies have the potential of increasing the surgical operating time, with the possibility that surgical morbidity may be increased, and the potential and these potentially impair the efficiency or the efficacy and success of ETV. We did a brief study at one of our hospitals just to document the variant anatomy that we saw during endoscopy of children under the age of 1, and included all children with hydrocephalus under 1 year of age that required CSF diversion. And of the patients that were evaluated, we found that only a fifth had a normal anatomy, which is to say that 4/5 of the patients that we see in our settings have variant anatomy, and this variant anatomy is present in the ventricular wall or the ventricular floor in half of these patients, and both the wall and the floor in another half of these patients. So this then implies that the variant findings are frequent in infantile hydrocephalus in our setting, and this variant ventricular findings increase the difficulty and the operating time, and also therefore equates to success or failure of ETV. So along with the ETV success score that Baya Kulkarni has very eloquently described in many, many publications and is quoted regularly, we have, in addition, the variant anatomy that begins to impair the success of ETV. So this, the ETV success score is, and that is where this focus of this talk is going to be, is what is the scoring system? It has 3 items. The first item is age. So if the child, as in this one, is less than 1 month old, you give the patient 0 point. If the child is 1 to 6 months, as in this child, you get 10 points. 6 to 1 year, 30 points. And then there's a jump to 40 points if the child is older than 1 year. And if they are older than 10 years, you give them 50 points for the scoring item of age. With the next scoring item is the etiology of the hydrocephalus. If it is a post-infectious hydrocephalus, as in this particular case, this scores very poorly on the ETV scoring success score system. If the child, as was shown by Samer, has a meningomyelocele or intraventricular hemorrhage or a non-tectal brain tumor, they score 20 points. And if there is aqueductal stenosis or a tectal tumor, this is a more favorable type of hydrocephalus and scores a little higher. The next scoring item is whether or not the child has had a previous shunt. If the child has had a previous shunt, they score poorly, and if they have not had a previous shunt, they score better. So it is the combination of this age, etiology, and presence of a shunt, and as I mentioned, the possibility of variant anatomy that is going to determine whether an ETV is going to be successful. So the ETV success score therefore predicts the chances of success when one is doing this ETV. In 0 to 30 points, the chances are that there will be only 1 out of 4 patients who will succeed. And I totally agree with Samir when he says we really should give that a chance, even if it is 1 out of 4 that is going to succeed. In our setting, putting in a shunt and then risking an up to 30% risk of infection or blockage of these shunts in children who may not be able to access care very quickly could be a disaster. So we do, when we are going for these missions, do offer the ETV to all our patients and explaining to the parents that there is a likelihood that this may not work because of the points that we have seen, because these points are 0 to 30 perhaps, but they understand that we will do the ETV and only go to a shunt if we cannot have any other option. Of course, there are instances where they come in with a scan and it shows a multiloculated hydrocephalus. We then explain to them that this is not going to benefit from ETV, but may need fenestration of the cysts and possibly a shunt. But in most other cases, we would proceed and do the ETV if it is at all possible. If one looks at the ETV points, if they score between 40 and 60 points in that combination of age, etiology, and shunt, the improvement of success goes up to 45 to 55%. And if the child is scoring 70 to 90 points, that is the most favorable scenario where 70 to 90% of ETVs will succeed. So the talk was about how do we determine in our setting, particularly the possibility that we shall have a successful ETV, and this gives us a snapshot and a way of defining whether that ETV will succeed. It gives us a platform with which to discuss and warn or discuss with the parents so that they are aware that this is not a trial surgery that we are doing, that we are offering them on the basis of the possibility of success or failure, and the reasons for doing it even when the points are low are, as explained, the possibility that putting in a shunt might result in a 30% risk of infection. So the message that this brief talk, which follows the excellent talk of Samir, is that ETV success score ranges from 0 to 90. And this number approximately translates into the percentage chance that an ETV will succeed if you follow these patients up 6 months after the procedure. And taking into consideration the anatomical variations that we mentioned earlier that we see, the ETV success score provides a valuable guide to predict the success or failure of an ETV. And this then is a very helpful way in providing an informed guide to parents by their care provider neurosurgical team. With that, a brief talk. I'll thank you very much for the opportunity of sharing this system with you during this talk. Thank you very much.
Thank you very much, Professor Qureshi, for this interesting talk. Any comments or questions?
Yes, Dr. Muhammad, may I have a comment?
Yes, please.
Thanks a lot, Dr. Qureshi, as usual, and Dr. Samir Al-Baba. Just a comment. It's a very clear and important and valuable message for all attendees that the trial of ETV, it's quite essential and valuable, and it's better than a permanent morbid shunt. This is a quite valuable message, and this is, I think, this is the message we are working on it. Me and Professor Nasser in all the observation courses. The trial of ETV, it's quite essential, quite valuable. better than a morbid shunt forever. Thank you very much.
Thank you, Dr. Omar. So any more comments? I just have one question for you, Moody. What about assessing an ETV by lumbar puncture? Like if you have the ETV or your query, if it's not well functioning, and you start having some collection through the ETV incision, do you do some lumbar punctures like
yes?
some
Thank you for raising that, Mohammed. I think that's a valuable question. If we find that we've done the ETV and it was a clean ETV in a child that has a good success score, yet we find that the fontanelle is bulging on the following day, hopefully we won't wait until the wound starts to leak. But if it is still a bit tense, before we get a diagnosis that this is a failed ETV, we will offer the child a lumbar puncture, and we may repeat it 2 or 3 times on separate days. And if that seems to encourage the ETV to begin to function, I don't know what your thoughts are on that, Samir, but we do lumbar punctures in that kind of scenario. Not all patients, but this patient that you were absolutely certain that your diliquous membrane was well opened, there was no scarring, the child had a good success score, and yet when you come to see the patient in the morning the following day, you've seen that the fontanelle may not be very tense, but is still quite full. We would go ahead and do a lumbar puncture on that child.
Professor Qureshi, thank you for this wonderful lecture. I truly learned from it. I fully agree with you. I believe Professors Chinali and Constantini published in this in the past, that patients whom you are confident the ETV is patent and it's working, but not enough, you can facilitate this differential pressure through the prepontine cistern to have this pressure gradient between the third ventricle and prepontine cistern by doing few lumbar punctures. I have tried it in few children, obviously without spina bifida, and I found it to be helpful. But again, you need to have a good, at the end of the case, if you have a good confidence in your ETV and it works for a day or 2 and then things are starting to bulge again, you can do obviously a dye study to confirm there's a dye going to prepontine cistern, or you can just do a few lumbar punctures and to speed it up basically and get the ETV going. And in my experience, it has been helpful in those selected cases.
Thank you, Mohammed. Any other questions?
I can see, Mohammed, I can see a question in the panel. Please, we would like to answer all questions. It's already answered?
Yeah, it's already answered. It's the question for the myelomeningocele repair. We do first repair, then follow the head circumference and ventricular size. If increasing before 6 months of age, we go to VP shunt, then ETV later, or what? So he's just asking again the same question for Samer. Samer already answered that we start with the repair and then we follow the head circumference and then we go for ETV.
I usually
yes,
ETV, Mohammed. I usually do ETV, Mohammed, at the age of 2 to 3 months. If the anatomy is favorable, I try to do the ETV after 2 to 3 months. Under the age of 2 months, I almost always place a shunt.
Okay.
My preference is to wait to 4 months or 6 months, but most babies will not allow you to wait.
So what do you think about when there are some points raised recently that when you do an ETV and you start the puncture, you have the membranes pulsating upward, which means that the tension in the prepontine cistern is higher than the tension in the third ventricle. And this allows the flow up to the third ventricle from the prepontine cistern and not the reverse. So this is one of the theories which was raised recently by some, that you say that this ETV is successful when you see the membranes pulsating and you find the flow is coming up to you and not down through the prepontine system. So they were asking how these ETVs work. And some raised the point that it is by the absorption through the subarachnoid space. And maybe that's why the lumbar puncture helps in some of the failure cases. What do you think, Samer and Moody, both of you?
Professor Qureshi?
We often find the membranes bulging up and down. You sometimes actually are not convinced that that floor is tense. Indeed, sometimes you find that you open the tubocinarium and the membrane is actually flowing quite freely, and you actually wonder whether there is a pressure or not. I still believe that the ETV in those sort of circumstances can still work. And what one then does is to try and get a hold of the membrane and then bring it towards yourself through a separate port and then do the ETV. And you find that these ETVs can still work. So it does not imply that there is such a pressure differential that the ETV will definitely fail. What are your thoughts on that, Samer?
The direction of the pulsations do not bother me. I did not notice in my practice, and I have a very high ETV volume, both ETV and ETV CPC. I never found the pulsations in which direction they go to matter. What matters is having a clear-cut communication between not only the prepontine space, but the intra-arachnoidal prepontine space. Sometimes there is a thick arachnoid surrounding the basilar artery, and people think that, well, this is enough, and that's not. You need to have communication between the third ventricle, the prepontine space, and you can see the naked basilar artery and some of the lower cranial nerves possible in order to trust your ETV. I agree, lumbar punctures can be helpful in those cases when you trust your ETV, but it's not enough, and the patient is still showing some symptoms. In my experience, I found this to be helpful, but the direction of the pulsations is not, in my opinion, does not lead to one way or another. Once we go in to do ETV, we have to invest in it and trust it and see how the patient is going to do after surgery. And if they show signs and symptoms of needing more help, we can do lumbar punctures. If they do not, then probably the right thing to do is to go for a shunt.
So how far do you, Moody, trust the CSF flowmetry in your scoring? If you use a CSF flowmetry and you find it functioning, and sometimes you still have an increase in circumference or some symptoms.
Mahmoud, can you hear the question of Beltagi?
It seems
maybe problem in communication.
May I have question or comment?
Yes, Moody.
I have to attend to a call. Yeah.
We can't hear you.
I have a comment, Dr. Muhammad.
Tell me. Sorry, repeat the question, please. I didn't hear that. Mohammed, can you hear me?
Yes. Sorry, so how far do you trust? Yeah, I can hear you very well now. How far do you trust the CSF flowmetry if you have symptoms still increasing a circumference or a bulge, and you have the CSF flowmetry show to be functioning?
I must say that I did trust it very much until I had a situation where the patient actually coned on me 24 hours later. So I'm a bit uncomfortable relying totally on that. I think the patient symptomatology must be taken seriously, and before you reassure the patient that you've done flowmetry, MRI, and it's been reported, it's recorded very well. You are seeing, I think it's the volume that you cannot determine on the MRI as accurately. So I have had my hands burnt with trying to rely totally on that flowmetry. What's your thoughts on that, Samir?
Yeah, I agree with you too. Yes, Samir, please.
Same thing. CSF flow studies or semi-CSF flow studies, I used to do them a lot, maybe 10 years ago. Nowadays, I rarely use them. If I actually want to know, especially in shunt malfunction cases, if I really want to know if there's communication in an ETV I trust, sometimes I do a dye study. Inject dye into the lateral ventricle via tapping the shunt, and then try to do a CT scan, make sure that the dye goes to the pre-pontine space. The flow study, in my opinion, does not make me decide on an ETV if it's working enough or not.
So you never repeated an ETV on basis of a flowmetry?
I truly follow clinical evidence. If there is, again, increased ventricular size, increased head circumference, clinical symptomatology, papilledema, I will look at a thin, fast, I look at thin cuts MRI. Most of the times you can see the fenestration, you can see a jet of CSF going through the fenestration. And I will do the flow study here and there, but not many times recently. And I will go sometimes tell the family I'm going to go to explore the ETV, and I see if it's occluded or near occluded and redo it again, but I always consent the patient for a shunt under the same anesthesia. If I go in to explore the ETV and I find it wide open, under the same anesthesia, I'll just put a shunt.
So if you have a patient with a shunt that is more than 6 months, what's the success rate of removing this shunt and doing an ETV? This is for both of you again, the question.
The studies I showed you from Italy, from China, from different places, all of them talk about 50 to 70% success rate.
So you remove the shunt, same session, do an ETV.
So you have, as I showed you, many options. You can remove the shunt, or you can fix it, revise it, and put a small tie under the valve. And in the last few years, I've been using programmable valve if it's available, and take it to the highest setting. And one of the valves in the market now has the virtual off option, where you can turn it off if it's available at your hospital. Otherwise, you can revise it and tie it off. Sometimes you can take it out. In babies or under the age of 1 year, I would take the shunt out and put a reservoir, and a Reckham reservoir after the ETV.
Okay.
The dilemma one has, particularly with this day and age of Professor Google advising a lot of patients. Patients will come in and say, my child has a shunt. I don't want this child to continue to have a shunt. He is now 8 months old. Can you please do an ETV and remove the shunt? And we're getting such patients. I had one just 2 days ago. And again, I think the approach that Samir, you have described is the more appropriate one, to either tie the shunt, but not remove it, because you really, the success score might have gone up to 70, but there is also that 30% chance that the ETV may not work. So absolutely. So one needs to dissuade that parent to say, look, we will do the ETV. We will leave the shunt in. We will tie it and before we remove it, we will keep that tie in place for at least a few weeks before we consider removing it. And by that time, you have also seen, hopefully, during your ETV, whether the choroid plexus is adherent to the ventricular catheter, which when you remove might end up giving the child a problem. So I think there is the tendency to believe that putting in a shunt and removing it is a fairly straightforward procedure. One can run into difficulties with small things like an adherent choroid plexus to the shunt catheter, and you're happily trying to pull it out, and there is a hemorrhage, which then goes and blocks off your ETV, and you are really in a disaster from a very small procedure. So one has to obviously think this through fairly carefully and scientifically, even though it's a fairly straightforward procedure.
Absolutely. Many options can be done after the ETV, should be discussed with the family, and every case, take it case by case. And the age is very critical. Older kids, I try hard not to take the shunt out, similar to the concerns you shared, and tie it off or upgrade the valve. But for younger babies, if they present like within few weeks or months after the shunt was placed, the shunt is not stuck, signs of a failure, those are the ones that sometimes I consider removing the shunt to place reservoir, although all options on the table, I discuss all of them with every family and we make the decision together.
Okay, there is a question on the panelist. Can we give chance to ETV even though with a history of meningitis?
It's difficult. The ETV success score tells us that really in settings of infection, you've got 0 points there. So trying to do ETV again, I mean, that was the purpose of trying to define the various point system that Abaya Kulkarni and his group have very eloquently described in literature. And if there has been meningitis, and that's part of the discussion we will have on the post-tuberculous hydrocephalus. I think we could perhaps have that answered during that, because the issue is very similar. The visualization of the floor, the fibrin deposits, the thickened fibrous tissues that you see are all manifestation of an inflammatory change. So I think maybe we can revisit that question again once we've discussed that in the post-tuberculous hydrocephalus talk.
Okay, thank you again,
May I have
Qureshi, for
comment,
this.
Dr. Muhammad?
Yes, please.
Yes, only short comment. I have just another explanation for the membrane pulsation. My explanation, that's when before going to fenestration, the floor of the third ventricle, the pressure is still high in the third ventricle more than the prepontine and interventricular system. When you put do the fenestration, there is a movement up and down of the membrane, which is like a dancing membrane. This is, I think, this is due to the pressure gradient until it becomes zero under the effect of the cardiac pulsation, diastole and systole. That's why the membrane go up and down. And I think this is a crucial sign of a successful fenestration rather than a failure. That the dancing membrane up and down, it means there is now a zero pressure point under the effect of the diastole and the stole effect of the cardiac. Thanks, Allah.
Thank you, Dr. Omar. So we can proceed to the next presentation by Professor El-Baba, the myelomeningocele in utero repair.
Thank you, Professor Beltagi. Can you see the slide well?
Yes, we can see and hear very well.
Thank you. I truly enjoyed this amazing conversation and discussion with the colleagues, and I always learn from Professor Qureshi, amazing lecture. So I will focus on this talk on the field of fetal in utero neurosurgical repair of spina bifida. This is a field close to my heart, and I'm hoping to share some input regarding it. We discussed earlier about the pathophysiology of spina bifida and its impact on development of the Chiari malformation and the hydrocephalus, and we discussed the rates of the rates of shunted hydrocephalus in low lesions like sacral lesions are much lower than like upper lesions like in the thoracic or cervical regions. So the discussion about fetal surgery started early in the 1990s, thinking about reversing the pathophysiology. As I showed you from embryological perspective, we start to see the neural tube defect around 28 to 29 days of gestation, almost 4 weeks of gestation. And this negative pressure gradient here at the craniocervical junction, because CSF is leaking into this spine bifida defect, leads to the Chiari and the obstructive hydrocephalus, as well as the aqueductal stenosis. So some colleagues thought about, if we reverse the pathophysiology by stopping the leakage from below, this may reverse or stabilize the craniocervical hindbrain herniation, and this hopefully can reduce the chances for hydrocephalus development, progression, or the need for a shunt. So the first reports came out in 1997. That was done at Vanderbilt in Tennessee. They did 2 patients, 1 died. They did basically a patch. They put a split thickness graft over the spinal cord placode just to almost plug it. And they found no improvement in those second baby. And the first one died. In 1999, 4 cases were done in Vanderbilt. They found no Chiari at birth, and only 2 of the 4 showed a shunt. And there was no discussion at that time about the motor function. And then in Philadelphia at CHOP, they did 10 fetal closures around the same time, late 1990s, but they did them early. The Vanderbilt group at that time, they did 28 to 30 weeks of gestation. And the CHOP group, they did it early, 22 to 25 weeks. And although there was 1 mortality, but the rest of them, the 9 of them, 4 of them required a shunt. When they put both data together, CHOP and Vanderbilt, over 100 cases, they found the shunting rate dropped to 44%. And there was a question about the improvement of the lower extremity function. And there was also some evidence from this early data that if we do the surgery before 25 weeks of gestation, that this actually can give potential benefit for both the hydrocephalus and the motor function. That's when the MOMS trial developed, or the management of myelomeningocele study. It was developed, funded by the NIH. Only 3 centers at that time were allowed to participate: CHOP, Vanderbilt, and San Francisco. And they did a prospective randomized trial comparing prenatal to postnatal surgery to look for hydrocephalus and motor and cognitive outcomes. At the time of the trial, which started in 2003, at that time, fetal surgery was only considered for lethal conditions inside the uterus. And we all know that spina bifida is not a lethal or fatal condition. And there were many unknown risks to both the mother and the baby. And what is the long-term impact on future pregnancies? There were a lot of unknown answers to many questions, and that's why the trial came on board. When the trial looked at the outcomes, the primary outcome was looking at mortality and the rates of shunting by the age of 1 year, and the secondary outcome was looking at cognitive and motor function at the age of 30 months. The trial was stopped in 2010, and the results were published in 2011. You can download this from Google, the New England Journal of Medicine. They looked at the results, and when they compared 78 babies who had fetal surgery under 26 weeks of gestation compared to the standard of care, which is postnatal repair, the rates of shunting dropped from 82 down to 40% at the age of 12 months. When they looked at the hindbrain herniation, it went from almost 100%, as we know, in the standard postnatal surgery to 64% in the prenatal surgery. Most exciting was the motor function. Here, 2 levels, functional levels, 2 levels below the anatomical level. That was the biggest good news, or the best surprise, when they found that the kids who had fetal surgery, they functioned 2 levels below their anatomical level. Like an L3 functioned like L5, and the L1 myelomeningocele, supposed to be in a wheelchair, functioned like L3, maybe walking with crutches, and the L3 walking with a walker or crutches, now walking independently with braces. And when they looked at the age of 30 months, 42% of the babies who had fetal surgery were walking independently. Obviously, there were risk factors. There are risks to the mother, as we can see here, as expected. There are higher rates of maternal complications related to oligohydramnios, placenta abruption, chorioamnionitis, preeclampsia. And when we look at the gestational age, on average, in the patients who had fetus surgery, it was 34 weeks and 1 day. And the most concerning was that 13% of the babies who had fetus surgery delivered under 30 weeks of gestation, and they had complications related to prematurity. So the take-home message from the MOMS trial was that although the fetus surgery is showing very promising results to reduce hindbrain herniation, reduce the rates of shunting for hydrocephalus, and improve the motor function, but there were concerns for increased complications related to prematurity. A follow-up study came out in 2016, looked specifically at the severity of the hydrocephalus prior to fetus surgery, and they found actually that if the ventricles in the fetus were larger than 15 millimeters and reach that stage of what we consider severe ventricular megaly, those babies are going to end up in a shunt regardless. And then this paper actually changed the way I and many fetal neurosurgeons, how we have the conversation with the mother if their fetus already has severe ventricular megaly, and how we counsel them. Many papers looked at other outcomes that were not studied in the MOMS trial, like the impact on spinal deformities, the impact on neurogenic bladder, the impact on bladder and bowel control. And although this was not studied in a prospective randomized fashion, but we know that fetal surgery is showing very promising signs in reducing the severity in neurogenic bladder. Most exciting recommendation came from the American College of Obstetrics and Gynecology in 2017, which recommended that here in North America, all women with pregnancies complicated by fetal myelomeningocele who meet established criteria for in utero repair should at least be counseled in a non-directive fashion regarding all management options, including the possibility of referral to a fetal surgery center. So now it's a national recommendation. All fetal diagnoses of spina bifida in the US, specifically myelomeningocele, should at least be counseled about the option of fetal surgery if they meet specific criteria. I was fortunate to be with a great team in St. Louis. Immediately after the MOMS trial, we were the first center outside of the MOMS trial centers to perform fetal surgery in May 2011, and until I moved to Florida in 2017, we performed 60 successful repairs. And here in Orlando, so far we performed 19, and I had the pleasure to perform also 10 to 15 cases internationally with other centers. And it has been truly an amazing journey to see the progression of this field and advances that are happening. And we published in 2017 the topic I discussed with you earlier, which is specifically looking at ETV outcomes and this very specific fetal surgery for myelomeningocele patient population. When we look at the inclusion or exclusion criteria for fetal surgery, we follow very strictly the MOMS trial criteria. The lesion has to be between T1 or dorsal 1 level down to S1. Any lesions below S1 are not considered, as we know, because those kids can do well anyway. There has to be an evidence of Chiari type 2 malformation or hindbrain herniation. In most cases, we have evidence of ventricular megaly, and the gestation age has to be between 19 and 26 weeks of gestation. And there has to be normal karyotyping on genetic testing of the amniocentesis amniotic fluid. The criteria for exclusion are long. Twins are not allowed, severe kyphosis, any cardiac anomalies, any history of placenta abruption, and many maternal contraindications, including body mass index over 35 and many other maternal exclusion criteria. When the mother typically is referred to us, the first thing we do, we go through the criteria. And we do, after the ultrasound, we do an MRI. Here you can see on this MRI, you can see the spina bifida defect around the lumbosacral region. We can see the hindbrain herniation and the ventricular megaly. And if the karyotyping and amniocentesis is negative, nowadays we do not only karyotyping, we do microarray to look very specific chromosomal deletions if available. So between the fetal MRI, the fetal ultrasound, and the amniocentesis, if the mother is meeting all the criteria, she and her fetus, and they're under 26 weeks of gestation, we offer them fetal surgery as an option. This is truly a teamwork in the operating room between neurosurgery, maternal fetal medicine, obstetric colleagues, maternal or obstetric anesthesiology, neonatology, pediatric surgery. We work as a team in the operating room, 2 different nursing teams for neurosurgery and obstetric, and continuous ultrasonography throughout the surgery. Throughout the surgery, we monitor the fetal heart rate every 5 minutes, and then after the uterus is open, we do it every 3 minutes. Here, the cocktail of medications for the fetus, a combination of sedation, paralytic, and atropine or epinephrine. We typically do fentanyl, picronium, and atropine to do the intramuscular injection for the fetus. So the mother comes in the morning after she goes through epidural catheter placement for post-operative pain control. She goes under general anesthesia. This is a machine where we do continuous amniotic fluid replacement, although I have performed this surgery in many countries around the world, and they do not see the setup. They do not have the setup that you're seeing in the pictures. Like in Brazil, they do not do continuous amniotic fluid replacement, and many other countries in the world, the setup is much simpler. And I can assure you, in most centers, including your centers in Egypt and more likely in Kenya and other places, you have most of the setup available. You do not need specific equipment for this type of surgery. So after the mother is placed in lithotomy position, she goes under general anesthesia. We localize the placenta and the spina bifida defect. We start with a low fenestrial incision. In some cases, we do this Alexis retractor to expand the uterus, but in most cases, there is no need for it. This is after a 25-week gravid uterus is explanted out of the pelvis. We localize the placenta and the myelomeningocele defect. In some cases, it's a myeloschisis, not myelomeningocele, and I will show you the challenges in between them. After placing sutures into the uterine muscle and amniotic membranes, we start with the cautery to do the hysterotomy. In the US, we do stapler, but in Brazil and in other parts of the world, they do cardiovascular clamps. There's no need for a stapler in every country. You can do this operation without all this fancy equipment if needed. I have been honored and privileged over the years to be mentored and continue to be mentored by the father of microneurosurgery, Professor Ghazi Yasrgul, who around 2013 truly pushed me to consider converting all the fetal surgery cases into microsurgery, true microneurosurgical reconstruction. So here we can see this is the uterine muscle, the amniotic membrane sutured or stapled. This is the tubing replacing amniotic fluid. This is the back of the fetus, and this is the myelomeningocele. Here you can see 2 different pathologies. This is a true myelomeningocele, but those are actually more difficult, challenging cases, which are the myeloschisis. You can see exposed lumbar fascia circumferentially, and those cases can be a little bit more challenging. I try in every case to perform a true multi-layered microneurosurgical reconstruction of the spina bifida defect. We use microscope for every case. As a neurosurgeon, I stand, when the mother in lithotomy position, I stand between her legs, the colleague obstetrician come from the side, and the neurosurgery assistant coming from the side, and the microscope come from the top. And this is a recent case here in Orlando, and we now managed to introduce the microsurgical technique for every fetal in utero surgery for spina bifida. Since 2013, we started doing a true 3-layer reconstruction. This is the P of the placode, P of the placode. Try to do a true reneuralization or retubularization of the placode. The 2nd layer is the dura, and the 3rd one is the skin. This is one of our older cases. You can see here, this is a myeloschisis closed only in 2 layers, the dura. You can see I did not touch the placode at that time, just dural closure, attempting watertight closure, followed by closing, undermining around the skin, putting some fibrin glue if available, and to do a primary closure of the skin. Then the technique evolved, and we started performing it in true 3-layer reconstruction. This is doing sharp microdissection and excising all those extra-arachnoidal transitional zone, or this extra-arachnoidal tissue surrounding the placode. I'm injecting some fluid now, saline, just almost like a tissue expander to elevate the dura from the underlying lumbar fascia. Now I'm doing sharp elevation circumferentially of the dura from the underlying lumbar fascia and paraspinal muscles. The first step of the reconstruction is now I'm doing a peel to peel closure. This flat placode, we are reneuralating it to perform a true retubularization of the placode. Occasionally, if you see a thick phylum that I'm confident it's the phylum, I will remove it. To go step by step for the residents and students in the room, here's some illustrations from some of our medical students. Again, this is now we're doing amniotic fluid replacement. Now you can see sharp microdissection surrounding the placode going through this layer. You can see in the diagram. The next step is to complete the tubularization. This is the flat placode in the top, and in the top right, you can see after the tubularization has been completed. And now you can see I try to do anywhere between 4 to 6 interrupted peel sutures, anywhere between 6-0 to 10-0 sutures under the microscope. The next layer, which in my opinion is the most important, is to perform the dural closure. In my opinion, the key of this operation is to perform a watertight closure. You need to stop the pressure gradient. Here you can see it trying to approximate the dura, sometimes the lumbar fascia as well if you can, to achieve a robust watertight reconstruction to give the spinal cord a new home. And in my opinion, the most important, to have 0 chance for CSF leak. The last step is to do the skin closure. We start with undermining circumferentially under the flanks to try to bring skin edges close by. In this case, this is an easy type of skin closure. You can see here the skin is a primarily closed on top of the dura without any challenges. How about if you have myeloschisis case and you have a defect in the skin that's around 2 to 3 centimeters? Those are the cases where we do inlay graft of, this is an alloderm or acellular human dermis, cadaveric human dermis without the epidermal layer that's processed, used by some plastic surgeons. I've found great luck by using it as an inlay graft in those similar cases and achieve a very nice reconstruction on top of the graft. But there are some cases when the defect is huge. In myeloschisis cases, that's when it's impossible to achieve primary or inlay graft reconstruction. Those are the cases you need to do an onlay graft and reconstruction. After closure of the uterus and the skin, we monitor the mother for 4 to 5 days in the hospital. We start to see lower extremity movements and knee extension day 2, and on day 3, you start to see ankles and toe moving. We try to push the pregnancy for elective cesarean section around the age of 37 weeks. And in most cases, you have beautiful healing. But even the cases when we used an inlay or onlay graft, you can see during pregnancy, you see epithelialization of the skin on top of the graft that can be managed just with wet to dry dressings without the need actually to take them back to surgery. And it has been at least 4 or 5 years since the last time I took any baby back to surgery after birth. All of them with simple wound care after birth, you will achieve good healing. I'm not going to discuss hydrocephalus in this talk because we already discussed it in the talk earlier today. But here you can see around 32 weeks of pregnancy, we do an MRI. You can see the healing of the skin on top of the graft. On T2 images, you can see nice CSF surrounding the placode and reversal of the hindbrain herniation. When we looked at our 60 cases we performed in St. Louis, all of them underwent successful repair, and we performed them around 24 weeks of gestation on average, and the average neurosurgical repair time was 43 minutes. When we looked at our gestation age at birth for our 60 cases or 50 cases, we found We were around 34 weeks and 4 days, a little bit, few days longer than the mom's trial gestation age. And most exciting was that at least 60% of our babies made it for an elective cesarean section between 35 and 37 weeks. We were fortunate, alhamdulillah, to have zero maternal or fetal mortality, intraoperative or postoperative. We had 2 perinatal neonatal mortalities a few weeks after birth due to prematurity complications. And our 60 cases, we had a 3.3% mortality. Mom's trial with 3%. Here in Orlando, right now, it's 0%. We do also around 6 to 12 months, we do follow-up MRIs of the spine. And with the tubularization, you can see nice cylindrical shape of the spinal cord and nice CSF space between the dural closure and the placode in many of the cases. When we tried to critically compare our 6 years of experience with 60 cases compared to mom's trial, 3 centers, 7 years, and 78 cases, the results actually, when we look at maternal, fetal, and neonatal complications, are very comparable, which tells you that busy centers with time, you will have very convincing low morbidity and lots of great outcomes for the babies. When we looked at risk factors associated with preterm delivery, we found the earlier gestation age under 23 weeks of gestation leads to higher rates of prematurity. So in our practice right now, we try to do most of the surgeries between 24 and 25 weeks plus 6 days. We have to do it under 26 weeks of gestation. And after the mom's trial, busy centers such as Philadelphia and many other centers are showing all of them very comparable outcomes. Most interestingly, when we looked carefully at the learning curve, we found that most of our complications or morbidity was in the first 10 cases. And as the team becomes more experienced, you'll find lower morbidity and better outcomes. As soon as the babies are born, we do assessment of the motor function while they're in neonatal ICU. Look, you can see in this baby, the ankles are moving, and we monitor them closely in the office to make sure they have good motor function, monitor it, and monitor the healing. When we look at hydrocephalus outcomes, again, I discussed with you earlier today the shunts and ETV and their outcomes. The mom's trial, 78 repairs, 7 years, 40% shunting rate. In St. Louis, we had almost 60 cases. We followed them for 6 years, and our shunting rate was 29%. Here in Orlando for the last 2 years, we have done 19 repairs so far, and our shunting rate is down to 16%. And if I can think about why do we have a very low shunting rate in this spinal bifida group we have here in Orlando, I think part of it is the combination. Number one, fetus surgery, it's reducing the Chiari, improving the chance for ETV to work. And now we're not only doing ETVs, we're doing ETVs with CPCs in the first year of life. And that's why I believe we have lower shunting rates, but obviously we need to follow this data long-term to see the impact on cognitive function, as well as some of those kids may require a shunt next year. So we need to follow this promising good outcome long-term to be convincing. The other technique to perform the fetus surgery described by some colleagues is to performing fetoscopically. Here in our practice, we're still not convinced this is the way to go. I do believe this promising technique to perform it fetoscopically has very amazing potential, but still the technique is not anywhere close to the multi-layered microsurgical reconstruction I showed you earlier. And also the fetoscopic surgery are showing some data last couple of years, a lot of concerns regarding tethering of the spinal cord. This is one of our recent repairs here in Florida. You can see as we become more experienced, we're doing much smaller hysterotomies and able to achieve very nice closures of the spina bifida without doing the large hysterotomies. This is our first few babies, beautiful photo of their smiles. In conclusion, fetal myelomeningocele surgery is gaining excitement and momentum after the mom's trial. Many US and international centers are starting to perform the procedure. Amazing outcomes are starting to come out. I've been fortunate to work with many international colleagues around the world, and we're glad to support you in any way possible. There is a learning curve to work as a team to get into this a good outcome time frame. And in my opinion, the first 10 cases are when most of the morbidity can happen. We've proved in our data that performing a true multi-layered microsurgical reconstruction of the placoid and neural tube may achieve longer surgery, but will not impact the length of pregnancy or increase complications as we used to think. ETV, in my opinion, and ETV CPC has a very promising potential in this very specific patient population. We need to take a closer look at the what is the best neurosurgical technique. Many colleagues can disagree with me that microsurgery is not needed. I have been quite convinced over the last at least 7 to 8 years that we should treat fetal spina bifida the same way we treat a brain tumor or brainstem pathology or any neurosurgical condition, and try to achieve the best microsurgical technique possible to give the children the best outcome possible. At the end of the day, this is a teamwork, and you cannot do it alone as a neurosurgeon. You have to collaborate with colleagues. Thank you.
Thank you, Professor El-Baba, for this nice presentation and huge experience. Looking forward actually for collaboration and doing some cases here.
Be honored to help in any way.
Oh, thanks. Any questions or comments?
Yes, please. Can I?
Yes, Professor El-Ghandour, of course.
Yes, well, thank you, Professor Samir El-Baba, for shattering experience. We never seen that before. But I just wonder about when you do that, you know that when we repair meningomyocele, as we use routinely, they don't improve lower limb still paralytic, bladder dysfunction, and they end with renal failure from the back pressure. These cases, you do surgery during pregnancy. When they are delivered, are they free, lower limbs moving well? They don't have any sphincters? Thank you.
Thank you, Professor, for the great question. So we believe, a lot of studies, even before fetal surgery, believe that the amniotic fluid itself is a neurotoxic environment for this exposed neuronal tissue. And many studies were done, animal studies have proven that if you cover the spinal cord and give it a healthy CSF environment, healthy CSF rather than neurotoxic amniotic fluid, this has to do with the neurotoxicity affecting the placoid during the pregnancy and may impact the motor function. So we do believe that the improved motor function in those fetal surgery babies we perform under 26 weeks of gestation has to do with the protection of the spinal cord, a fluid neurotoxic potential environment. In regards to the sphincters, although neurogenic bladder or bladder and bowel control were not studied in a prospective randomized fashion, as I showed earlier from some of the studies from Philadelphia showing very promising results that children who had fetal surgery, they tend to have a less severe neurogenic bladder, and a small percentage of them will have reasonable sphincteric control. I think all of that has to do with the early protection of the spinal cord from this neurotoxic environment.
Thank you again.
May I have a question, Dr. Mohammed, please?
Yes, please, Professor Ahmed.
Thanks a lot, Dr. Samir. Very interesting work and very interesting presentation indeed. I have two questions, please. The first one, what's your tricks to lower the maternal complications during these procedures? And the second question, do you try any intervention regarding fetal hydrocephalus surgery or not? Thanks a lot.
Thank you very much for the question. We all know that fetal interventions for hydrocephalus, there was an interest in the 1990s or even before that. There was a high mortality rates, and the interest has plummeted up to today. There is no evidence whatsoever right now, or at least scientific evidence, that doing any fetal intervention for the hydrocephalus has any promising results so far. So in our experience, we just focus on reversing the pathophysiology of the hydrocephalus by performing the fetal repair of the spina bifida, hoping for hindbrain herniation to improve or resolve, which we see in over 70% of the cases, and hoping this will impact the progression of the hydrocephalus and hopefully reduce the rates of shunting, as I showed in the results earlier. But we do not touch the hydrocephalus itself or do any procedures in utero at this time.
And the second question, how to lower the maternal complications, please?
So you need, in my opinion, to lower the morbidity, it comes with experience. You need to work with a team you're comfortable with, and you need to follow specific protocols. And as I showed you earlier, there's a long list of exclusion criteria, both maternal and fetal, and operating on the right candidate and careful selection is the way to reduce morbidity, in my opinion.
May I ask a question?
Now I have the pleasure to introduce Professor Amr Saman. I just called him, he's my colleague, professor of neurosurgery at Cairo University. I had discussion with Amr 1 year ago about fetal neurosurgery. As you all know that we have a very high percentage of these patients in Egypt with meningocele or myelomeningocele. And we had discussion 1 year ago, me and Amr together, that we would like to introduce such experience in Egypt by the support of Professor Samer El-Baba. Amr, please go ahead and start.
Hi, Samer.
Hi, Amr. How are you?
Hi. Actually, we had the pleasure to meet in Germany. We were faculty in the Baltic Sea course together, and we had long discussions about this. So until we meet physically again, until all this is ended. So let me just ask you a couple of questions. First is a logistic question, because I know the hospitals in the United States. I spent some time there. So in Egypt, we have our main hospital is separated from the gynecological and obstetric hospital. So do you think it's easier or more realistic to just bring the microscope from neurosurgery to OBGYN, or the other way around, that they would come to our OR and work with us for the facilities of the neurosurgical equipment? And the second question would be, you said you start from D1 to S1. So some cases, they have a congenital kyphoscoliosis. Is this a contraindication, or you can work around with this?
Thank you, Amr, for the great question. So in St. Louis, I had a different setup. I operated in the obstetric hospital, very separate from the children's hospital, and everything went very well. Here in Orlando, our women's hospital and children's hospital next to each other. So there's no difference where to do the surgery. I've seen different setups around the world. In my opinion, both are successful. As long as you have a NICU available, all what you care about is to perform this surgery safely. And if God forbid, there's a complication intraoperatively and you need to deliver that baby that day or in the first few days after surgery, you need to have a neonatal ICU available to handle premature baby. So the setup, in my opinion, does not matter. Whatever is logistically possible, I've seen it both ways and they both work fine. The second question I believe you had regarding
kyphoscoliosis.
One of the contraindications is having kyphoscoliosis in the fetus that is more than 30 degrees, 30 to 50 degrees, I believe. Recently, we declined a fetal myelomeningocele candidate just because of kyphosis. It is very challenging in a severely kyphotic fetal back to perform a safe surgery through a small hysterotomy. So
Yeah.
severe kyphoscoliosis is one of the criteria for exclusion.
Okay. Thank you.
Yeah,
Actually, I would like to add something. Dr. Nasser, Ihab al-Rifai have done 2 cases of in utero fetal repair for myelomeningocele here in Egypt with
really?
one of our professors of obstetrics in a private hospital. So for the setup, I think it's doable. All what we need, if Samer agrees, that the most important is the anesthesia and the obstetrician. And I think we can contact also, we have to know who is the obstetrician who did that and what's his experience. Because I think this is doable, not the problem of the microscope. It's the most importantly is the obstetrician and the anesthesiologist. If you can comment, Samer, if this is...
I agree. This is a teamwork. We will be glad to support you with our protocols. Welcome your teams to visit at any time. We always welcome, obviously after the COVID pandemic, but before COVID, we welcome many international teams. We hope to welcome you in the future to come and visit us. I would be glad to help you in any way possible. You need a obstetric anesthesiologist who's interested and comfortable. You need a maternal fetal medicine specialist with subspecialty expertise in obstetrics to be interested and comfortable. And you need an ultrasonographer and a neurosurgeon. To be very frank with you, all of you in this audience are experienced, talented pediatric or adult neurosurgeons. In my opinion, the neurosurgical technique is the easiest thing of this operation, knowing all of you and how talented you are. So all what you need is the collaboration. Let us know how we can help you in any way.
Okay, thank you, Samer. And we can proceed to Professor Qureshi last talk about ETV in post-tuberculous meningitis. Professor Qureshi, are you here?
Yeah, I'm here. Can you see myself?
Yeah, we can see now.
You can? Okay. So let's, we'll come down to earth now after that brilliant foray into outer space, as it seems from us here in sub-Saharan Africa, but a beautiful talk, Samer. I mean, it really is, we've spoken about it before, it's really an eye-opener, and it's very, very extremely gracious of you to be able to reach out and say you're happy to come and give us a hand. Just before I start my talk, I was going to bring up the subject of wearing my CANS presidency hat to perhaps through Nasser, who's the secretary of CANS, to suggest to our various member states to see which one of our other groups in Africa may want to develop some collaborative protocols with you. You've worked in various setups, and we could then select out a center of excellence for this kind of work somewhere, both in North Africa, in South Africa, and where there's a lot of meningomyelocele in sub-Saharan Africa. So we look forward to this, and I really appreciate the kind of humility and humble way that you have presented this, and thank you again for a brilliant, brilliant talk. Mine is to go down to give a brief overview of how one manages post-tuberculous hydrocephalus, because there are instances where one is going into endoscopic third ventriculostomies, and then one finds a situation where you have a patient who's come in with post-tuberculous hydrocephalus, and the temptation is to go ahead and do the same in this sort of scenario. And for those who have not managed these kind of cases, I thought I should give a broad overview of what we are dealing with. Some of our clinicians and colleagues from Egypt are very well versed with this pathology because TB is quite high in some of our countries, but others may not be. Just a quick overview, TB is amongst the most prevalent infectious disease worldwide, caused by Mycobacterium tuberculosis, first discovered by Robert Koch, a German microbiologist. And it was initially had become unfamiliar in the West because they thought they had managed to get over this with appropriate treatment and precautions. But now, because of global migration trends and increased survival of our immunocompromised patients who have on treatment for HIV, chemotherapy recipients, etc., we're beginning to see this even in the West more commonly. The WHO estimates that there are 8 million affected people affected by TB globally annually, of which 95% live in these developing regions, which are shown in blue. Of these, 2.6 to 2.9 will die as a result of this affliction, and 6% of these are children under the age of 15. Multi-drug resistant TB, defined as resistance to at least isoniazid and rifampicin, has now become a concern, and 3.2% of new cases are, that is over 250,000, are multi-drug resistant TB. Cerebrospinal, CNS TB is due to a hematogenous spread to the brain and meninges. And here is that discussion we were having earlier about what to do when there is meningitis. This results in TB meningitis. Tuberculomas can form, abscesses and paraspinal TB abscesses can also develop. And TB meningitis is an acutely life-threatening condition. And children under 6 years are most at risk. The presenting features are fever, meningism, seizures, vomiting, and an impaired conscious level. The neurosurgical intervention in tuberculous meningitis is essentially in the areas that are outlined here. There is the acute management of the raised intracranial pressure, which is with emergent extraventricular drainage. One has to do the CSF diversion for longer term management of the hydrocephalus. The incidence of hydrocephalus in these situations has been reported between 30% in some centers to up to 80% in some centers. CSF diversion is required in 30% of all cases, with 2/3 of these being under 6 years of age. The problems following TB meningitis include impairment of the child's cognition, emotional disturbances, poor school performance, motor impairment, blindness in up to 80% if treatment is delayed. And this is a particularly vicious condition of which about 12% will die. The outcomes have been improved by early and aggressive medical treatment and control of raised intracranial pressure. And that is the key to survival of some of these patients. The CNS tuberculosis can present with essentially what looks like a large granuloma. This is an example of a tuberculoma with associated hydrocephalus. And the hydrocephalus of tuberculous origin is a difficult complication. It is dreaded when it occurs and presents clear challenges to the medical team. Currently, there doesn't seem to be an agreed consensus on treatment protocols. So each center seems to have developed specific protocols from their own particular standpoint. So there are common themes that run through these protocols, and we'll just go quickly through them. This hydrocephalus may be communicating or non-communicating in nature, and often a combination of both, because both absorption is impaired because of the inflammatory change, and adhesions cause obstructions within the ventricular system. Cerebral dysfunction is not just due to the raised intracranial pressure, but also due to the ischemia that results from the vasculitis occurring in combination with the edema and the cerebral and the CSF outflow obstruction. So optimal and urgent treatment of the raised intracranial pressure therefore becomes crucial if one is going to get a satisfactory outcome. What the aim of effective treatment is the control of the infective process via a medical treatment with medication, control of cerebral edema. Mannitol therapy is often used in this sort of situations. Corticosteroids have shown to reduce morbidity, and even though this is an infection, dexamethasone given commencing early along with the anti-TB treatment is helpful. There is the control of hydrocephalus through external ventricular drainage, and as I mentioned, the long-term management of hydrocephalus. The dilemma of CSF diversion is the outcome depends on the severity of the disease. Shunting often results in shunt failure due to the high CSF protein and ventricular wall debris and can be a nightmare. ETV success rates of up to 65% have been reported, but as we shall see, there is a place where it should be done and a place where it should be avoided. Failure of ETV is often due to the thickened floor, which really results in the details of anatomy being obscured as a result of that fibrosis. So we are guided by what colleagues internationally have been practicing. Post-tuberculous hydrocephalus is difficult to treat endoscopically as compared with other forms of meningitic hydrocephalus, especially in the acute setting. So obviously it should not be left to the first or second year resident who's just learning how to do the ETV to go and manage these cases. There are various references that are available all across, and as I said, we are guided by them. In the acute stage of tuberculous meningitis, the hydrocephalus can be intense. The neurological impairment can be quite severe, but one is well advised to avoid the use of endoscopic third ventriculostomy in the acute stage. And I think there's a message here. One of the key messages is try and avoid ETV in the acute stage. If CSF diversion is necessary, it's appropriate to put in an external ventricular drain, and that time it's reasonable to perform a neuroendoscopic ventriculoscopy at the same sitting. And if possible, one can try and do the ETV, but do not rely on it to be effective, and therefore leave an external ventricular drain in situ post-operatively. Some authors tend to use the Ommaya reservoirs, and this has reported in success in avoiding shunting. So basically, you put in the external ventricular drainage, and then later leave an Ommaya reservoir, and hopefully as the inflammation settles, you might avoid shunting. This is the view that one gets when you go into a case where you have TB, hydrocephalus due to tuberculous meningitis. There is very high protein, so you hardly are able to look at the anatomy very well. And in slightly later stage, you'll see thick fibrin strands that obscure one's view, and that's what results in the ETV not being successful. However, in the chronic stage, the use of ETV in the subacute to chronic stage becomes more reasonable. It seems justified as the first line of treatment for hydrocephalus. So this is the second message. The first one is avoid ETV in the acute setting, but in the subacute and chronic stages, if the patient presents themselves, then it's reasonable to use it as a first line of treatment. However, one must look at each case individually. Here is an image of the tubercles that one can see on the choroid plexus and on the third and the ventricular walls. And the third ventricular floor becomes quite thickened, and one needs the requisite experience to be able to discern the anatomy, and remaining well anterior to where the basilar artery is likely to be in this sort of region, you then perform the perforation with a blood instrument or a diathermy probe without the cautery itself. And once one gets in there, there's a lot of irrigation that may be required to break down a lot of the fibrin strands that one sees in there. And then the stoma must be quite wide in order to ensure that there isn't a closure of that stoma very quickly because of the thickened tissues and the inflamed floor. One then goes through the basal cistern, and most often one finds a lot of fibrin strands. If they can be washed out and cleared, that helps, because then that prevents the unblocking of the stoma. And just as I mentioned earlier, it does present a lot of challenges, but I hope through this brief discussion I've been able to show you that whilst the management of post-TB hydrocephalus is a challenge, it can be done with due caution. This, for those who haven't visited Kenya, is the image that is taken in the Masai Mara National Park during the world-famous migration. And we hope that one of these days, when the pandemic is over, we shall have the opportunity to have you, to host you in Kenya, so that you can see some of these sites. Thank you very much. That was, again, just a quick overview of what post-tuberculous hydrocephalus is all about.
Thank you, Professor Qureshi, for this fascinating presentation. Any questions?
I think it is time to close the webinar. I know that we are somewhat late, and Professor Samer El-Baba has a clinic. And now I would like to thank our speakers, Professor Samer El-Baba. Thank you, Samer, for accepting our invitation and for contribution to this session, and for honoring us by your presence with us today. Thank you very much, really, and sorry for taking much more time from your clinic time. And I would like to thank Professor Mahmoud Qureshi for these presentations and for contribution. I would like to thank Professor Mohammed El-Beltagi, Professor Omar Youssef, Professor Osama Al-Ghandour, Professor Amr Al-Saman. Thanks to everybody who contributed to this webinar, either by speaking, by discussing, or by attending. Thanks to Eva Pharma for organization. Thank you very much.
My honor. Thank you very much, and shukran jazeelan.
Thank you.
Thank you. Thank you very much. Thanks.
Bye.
Bye.
Bye.